Hi everyone, Dr. Scott Sigman here, inviting you to check out some great information at the Business of Medicine session at the upcoming OSET Orthopedic Summit meeting. The session is sponsored by Veradigm and will run from 7 to 10:30 a.m. Pacific Time on Wednesday, September 18th in the Caprice 6 and 7 rooms at the new Fontainebleau Hotel in fabulous Las Vegas. Okay, this is going to be a super fun episode to listen to. We take a little pivot today. We're bringing on Theresa Bowling, who is, as far as I'm concerned, the queen of regional anesthesia. She has really been involved in developing these awesome blocks that we use for surgery now to minimize your pain, to minimize opioids. We're colleagues. We basically started in practice around 1995, and we share the journey through our opioid sparing journey that we've been on. And she's just so passionate, and she's really wonderful in the way she explains things. So all of our non-physician listeners out there, I think you're going to really enjoy this. And then, of course, we talk about One World Surgery, which is a passion for us, which is our mission trip that we take every year to be able to share and help the people of Honduras and the Dominican Republic. Again, a really fun episode. You are going to enjoy it, I promise you. Dr. Scott Sigman, hashtag follow the fro.
From medical media, this is The Ortho Show.
Hello, world. Dr. Scott Sigman. Yes, your favorite opioid-sparing orthopedic surgeon here for another episode of the Ortho Show podcast, where everyone knows we bring you the best of the best. We are pivoting just slightly out of orthopedic surgery. We're talking to one of my dear, dear friends who's an anesthesiologist. She is literally the queen of regional anesthesia. Theresa, please adjust your crown for us a little bit. It's off to the side. Perfect. Thank you. Teresa's the director of anesthesia at the Connecticut Orthopedic Institute in Bridgeport, Connecticut. She's the co-director of the Regional Anesthesia and Acute Pain Medicine Fellowship. She started this little thing called the Stanford School of Regional Anesthesia. And we had an amazing opportunity to share time together down in Honduras for One World Surgery, which we'll talk to. But Theresa, so awesome to have you on the show.
Scott, so awesome to be on the show, and I'm really excited. And thanks so much for inviting me. Really an honor.
No, it's fantastic. So we always like to pivot a little bit away from that boring orthopedic stuff every once in a while. And, our listeners like to find out, is there other stuff that's happening that really pertains to us, in the operative world? And I thought it would be awesome to bring you on board to be able to share your experiences. So we always start at the same place on the Ortho Show. Where, where is our doctors in the family? Where'd you grow up? How did you decide anesthesia? Give us a little short tidbit on that.
So I am a New Yorker, always will be a New Yorker, even though I lived in Connecticut for 30 years. Born and raised in Long Island, about 30 miles out of New York City in a town called Brookville. And apparently, according to my mother, wanted to be a doctor since I was 5. Whether that's truth or not, who knows? But nevertheless, it laid the groundwork, and I went straight through, never looked back. That was my trajectory from the get-go.
All right, so you stuck around. You weren't going to go very far for college, so you went to Hofstra. That was one of the options that was close enough to be able to go. I love those New Yorkers, man. You guys just can't get out. You can't go too far, but I love it. So Hofstra right through. You're like, I'm going to medical school. I'm going to grind this thing out. What's my plan?
Yeah, exactly. So went to Hofstra. Part of staying home was I'm an equestrian. So I was riding competitively on a junior level and had the nationals in November. So it made sense for me to stay home insofar as not to commute. And then I was really successful. And so I thought better to be a big fish in a little pond than vice versa. And that gave me the opportunity to pick from medical schools. So went off to Syracuse State University of New York, spent 4 years up there, and then ended up in Connecticut. Couldn't get back to Long Island. I don't know about what orthopedics looked in 1995, but there was an anesthesia, not a lot of anesthesia jobs. So
it was tough times, and it was tough times in 1995. The economy was good, but in medicine, people were going other places and things, and so there weren't a lot of jobs, even within orthopedics. I sort of stayed in Massachusetts because that's where the family was at the moment, and but I agree with you. But all right, so from there though, you're still staying Northeast, and you're heading to Yale for a little bit of a residency in anesthesia. How was the decision on anesthesia? I think that's an interesting point.
So I was going to be a pediatrician, and now that you've gotten to know me a little bit, you know how bad of a choice that would have been.
Yeah, you're not.
And my second rotation was anesthesia. And I'll tell you, what drew me to it was the people. And I think you would agree with this, and so would your listeners who are doctors, that certain personalities are drawn to certain specialties, right? I mean, that's why I get along to both orthopedic surgeons, right? Because we're like-minded. I love the operating room, thought about being a surgeon, but quite frankly, in the early 90s, being a woman surgeon was no good deal. And most of the women surgeons I knew were pretty unhappy. But the anesthesiologists were really happy, and they had a lot of fun in the operating room, and I was drawn to the procedures, and that was the end of that. Decided in my second rotation.
How about, these issues do matter to all of us as we choose our career paths. The ability to have time with family. I mean, you were going to have a family, you're married, you're going to have kids. I mean, how did that play into your decision with anesthesia?
Huge part. I knew I love my family. I'm a very social person. I love my friends. I love to travel. And, you remember back in that day, again, you and I are getting older here, doctors were not working part-time or working set hours, right? We worked, when I was a surgical intern, I went to work at Friday morning at 6 a.m. I came home Monday night at 6 p.m. What kind of life is that? And anesthesia at that time gave you the opportunity to have a life. Now, of course, fast forward 30 years, who knew you could be a radiologist and work from home?
There's some other jobs that were out there within medicine that were still probably better for family life because, in anesthesia, you're still taking call and you're in house and there's labor and delivery. And it's depending on how big your group is, there's a commitment.
Yeah, I do 24-hour call and stay in the hospital for 24 hours, and labor and delivery is the bane of my existence. So if I could do nothing but orthopedics and spine surgery, I would be very happy. And in fact, that will be the next step I take when I start to slow down, because that's what I'm passionate about. And that's what I love.
Well, I'm not gonna shout out your age because I would never do that. But I'm 59, so I can shout out my age. But I can't even imagine. Like, they don't even let me take call anymore, Theresa. Like, literally, they won't let me operate on a broken bone anymore. So, I've got my young bucks that take over the call for me, and I appreciate that. Dr. Sigman in particular, we love you. But I mean, God bless you. But I see the same thing. We have senior anesthesiologists in our hospital. Some are in their 70s that are still taking call. I'm like, oh my God, that's not where I want to be. But how much longer do you have left? What do you think?
I think that I'm going to be wrapping up the call situation in the next year or two, because I am 59 in June. So you and I are definitely contemporaries in more than one way. And then, we'll see in the next couple of years when Caden graduates, my son from Boston College, then I'll slow down. Maybe I'll come work with you.
I love it. We'll be ready to rock and roll for you for sure. Now this, your personality is perfect for where you are, what you do. And I think our listeners and viewership is starting to get a sense of that. I mean, you really do have this sort of surgeon's mentality. Let's get this thing done. We got to keep moving. Let's come up with innovative new ideas, right? This isn't good enough. And so let's start with that, right? So it's 1995 and you and I are just ready to go into practice at this point. And man, the opioid crisis is in full swing, right? We are using opioids like they're candy. We're giving out 60 pills, 90 pills. Everybody's getting them. That's what we're told to do. Your pain scores, your happy face, your vital sign, all of these pressures that made us use these opioids. It was not easy. I mean, we didn't have a lot of opportunity for options back at that point, did we?
No, not at all, right? And you hit the nail on the head, right? Everybody was pushing opioids. The goal was zero pain, right? There was no tolerable pain. You should have no pain. Like, what were the ads in the journals and in TV? Like, nobody should have pain. If you have a headache, take an opioid, right? So we graduated, back in 1995, and there weren't a lot of options. Regional anesthesia back then was, of course, around, but it was really not popular. A lot of people weren't doing it. There was no protocols, no procedures. And I realized early on that, if you could numb one part of the body just to dial it down, numb the arm instead of having general anesthesia, how could that not be better, right?
Yeah, so perfect. That was a great segue. I was hoping you'd get there for Judy, my mother. So tell us again what regional anesthesia is versus general anesthetic.
Well, regional anesthesia is you're numbing the part of the body, the regional part of the body, the region of the body that's having the surgery, as opposed to general anesthesia where you're numbing the entire body and the brain. So you're unconscious from a holistic standpoint, or just the part that's having surgery is unconscious.
And right. So regional blocks in 1995, you had this electrical stimulator, thing, which was just completely dumbass, pardon my French, but literally it's like randomly hoping that you ping a nerve so you kind of know where the nerve is. you're not looking at things, you don't know where the blood vessels are, and then you go ahead and inject this anesthetic around where you think it's supposed to go. Pretty much what you were doing?
Almost worse than that, actually. I have a video from a hospital that is famous for orthopedics that I shall not name back in that time where they were trying to elicit paresthesias. So I have a video of a nerve block in the neck where, I kid you not, it was like, are you having a shock? Are you having a shock?
Please
Is it a
stop.
really good shock? I swear.
Please stop. Please stop.
And I look at it now, you get a paresthesia, you're like, stop.
That's
So it really was barbaric.
amazing.
Anatomical landmarks, which, even then was challenging, but now with the obesity being everywhere, trying to find an anatomical landmark is, can be impossible.
All right, so let's dive into this a little bit further, because it's so amazing to me to reflect back at 30 years, right? We're talking 30 years. And in 1995, when I was taking care of a patient and doing a knee replacement, you would do a spinal, maybe you did like a nerve block, we're using these short-acting anesthetics, which wear off at the worst possible time. And we are narcotizing every single patient. So what happened? You had a knee replacement, you'd stay in the hospital for 3 to 5 days.
Right.
And then we send you to a rehab hospital for like 2 weeks. And why? Because we keep giving you opioids. You're nauseated, you're constipated, you can't keep your eyes open, you can't get out of bed. And that's how we were treating patients.
You couldn't rehab. That's exactly right. I mean, they're probably getting admitted the night before back then, right?
Yes, that's right. So we could give them narcotics before we start the surgery as well. I mean, we laugh about it now, but there's so much truth to it. And the other problem was, we didn't have a lot of choices with anesthetics, right? I mean, anesthetics work. They create they block the sensation or the nerve impulses, if you will. We don't have to get too crazy, but they block the nerve impulses so you don't have pain. The problem is they wear off, the ones that we were using, within 6 to 12 hours, maybe 18 hours, which was the worst time to have it wear off. You get this horrible rebound pain, right? And then we'd load you up on even more narcotics.
That's exactly right. You're trying to play catch up, right? And we didn't understand a lot of what was going on, right? So it was kind of like, you were just walking through the dark, trying to get your way through. And there was no, when I got my first job, after leaving Yale, it was catch as catch can. Like, this anesthesiologist did a block, this one didn't do a block. This one used 0.75% Marcaine, so the patient couldn't walk for who knows how long, and they couldn't rehab, and the other one's block were off in 2 hours. So naturally, you didn't have any buy-in from the surgeons because it was completely unpredictable.
Yeah, no, I completely agree. And again, I want to be clear to our listeners, and I know there's a lot of opioid zealots out there that get mad at us when we talk about opioids as being bad. Look, opioids still have their place, right? For end of life, for cancer patients, opioids do provide significant pain relief. The problem is they are highly addictive. So for the near death and cancer patients, we don't want you to become addicted to the medication. We want you to be able to have pain relief. And so I think that's a really important message that's out there for our patients at this point. So, all right. So, and again, the other thing is I'd like to say is that, you and I were good doctors. We were doing what we were told that we were supposed to do, right? Opioids provide pain relief. That's what we were doing. We didn't have any other options, and we were just following along. We weren't bad people. I mean, there were some bad eggs out there, dope sick. You watch these other shows and things, but right. Would you agree that most of us were just thinking about what we should do that's best for the patients?
Well, that's the way we were trained, right? So, we would draw up morphine, we weren't using Dilaudid back then. Everybody would get 1 milligram, 2 milligrams of morphine. Morphine was the first narcotic you went to, even Demerol back then. Remember Demerol? Talk about puking. And so it couldn't be a worse drug. Everybody was throwing up in the recovery room, there was emesis basins everywhere.
Oh, you're a classic.
But the sad part of that is I still have new residents that come and they draw up Dilaudid when they come to our practice. And I look at it, I'm like, step away from the Pyxis. Get rid of that Dilaudid. I go, don't ever draw a Dilaudid up for any orthopedic case, ever, as long as you live.
I love it.
And that's really our mantra in my practice. And agreed, to clarify, opioids have a place. There's no question about it. But if you're doing regional anesthesia and a multimodal analgesia kind of pathway, you shouldn't need them.
Yeah, so again, for our listeners, we're going to do regional anesthetics now with these longer acting anesthetics that can last, 24 to 72 hours, if you will. And then we use multimodal. That means we're using all these other medications that are non-opioid, non-addictive, that have different pathways to help with your pain. And you've been an absolute, opioid-sparing superhero, establishing these ERAS protocols, enhanced recovery after surgery. And that's what I want to talk about next. And I want to talk about that sort of transition. When did you, when did the light bulb go off for you that there was going to be a better way other than this stupid thing to stimulate people's nerves, to be able to do better job with regional anesthetic? Give us the important aspects.
I think it was pretty early on in my private practice career. And back then, the opioid crisis wasn't on the table, right? So what we're trying to do is reduce opioids to avoid the side effects, the nausea, the vomiting, the constipation, faster awakening, decreased length of stay, right? Because we're partners with the hospital, the surgeons, and the nurses, right? So our goal is to provide better care and get them out sooner. So I was getting away from narcotics. At that point, Zofran was coming on board. We were getting new medications and propofol, right? I grew up on the day of barbiturates, using, pentothal to induce patients. Now, all of a sudden we had propofol.
So tell us what that means. What's propofol, the vitamin, the milk of anesthesia? Tell us.
Amnesia, the Michael Jackson drug, right?
Yeah,
We're not doing
right.
that so much anymore. So, propofol is a rapidly metabolized anesthetic used in small doses for sedation, large doses in an infusion for total intravenous anesthesia. And we use that for all of our spine cases, for example, and for our total joints. It wears off rapidly, and it has antiemetic properties, some anti-nausea properties. So it's the best of all worlds. It wears off super quickly, and you don't get nauseous from it. It's non-opioid. Pretty much any of your listeners that have had a colonoscopy have had propofol, and they know you wake up, nothing ever happened, and you feel great.
Yeah, awesome. All right, so we're making some advances on the anesthesia. We're trying to avoid opioids as much as we can, even in the operating room, right? It's like the standard of care was always, pop in some Versed or something to make people relax, but then also throw the opioids in. So you're coming up with ways and ideas to minimize opioids in general anesthesia, but then something had to click for regional anesthesia as well. Tell us that story.
Yeah, so I was trying to organize a program. We were using nerve stimulators. It took a long time. Surgeons, operating room time is expensive, and surgeons have not a lot of time. So we were doing blocks in the operating room. So one of the reps for the on-Q pump, which is a delivery device for local anesthetic, saw me doing blocks in the OR, pulled me aside and said, "Hey, listen, you look like you're really good at blocks. You're really passionate about it. How would you like to go to Duke for 3 days and shadow our ambulatory center there? They're doing ultrasound guided perineural catheters." And my ears went up. I'm like, "Excuse me, what are you talking about?" So I'd had a lot of passion for Duke. I'd wanted to go there for college. I wanted to go there for medical school. They were not going to have me. So I had the opportunity to go to Duke and get a bumper sticker and put it on my car. I was in. And so I went down there, and I have to tell you, I was astounded. They were sending home patients that had I'm sure you've seen these in journals, where their arm gets stuck in the wood chipper or whatever, and there's nothing left of it. They were putting perineural catheters in these patients and sending them home an hour away from the clinic. And these patients, and using ultrasound, and it was like, they were done in 10 minutes with each block. And I came back like a bull in a china shop.
So again, for the listeners, so ultrasound, we all know of ultrasound. It can be used, during labor and delivery to check out your baby, et cetera. You can use it to see anatomy. You can see things. You can see the nerves and the blood vessels. And this perineural catheter means you're taking a catheter and putting it right next to the nerve, and you're basically this flow of anesthesia so that the patient's not going to have pain and discomfort. Brand new concept and idea, which was not mainstream at all. What year was this?
This was about 1998.
Wow, that's really early.
I couldn't believe in rural North Carolina they were doing this. Now, granted, it's Duke, but I mean the patients were out like really out in rural areas. And here we are in Fairfield County, Connecticut, and we're using nerve stimulators and trying to elicit paresthesias to do nerve blocks. And I was like, how is this happening? So, I got back in August, and I set a deadline for November 1st and said, we're going to do our first femoral catheter for a total knee, and we're going to use ultrasound. And I wrote a business plan. I presented it to the administration. I went to the orthopedic surgeons who I had a good relationship with, and I made them part of the team. Like, that's a really important part of this whole discussion, is if you want to have a successful regional anesthesia program in orthopedics or whatever it's going to be, you have to have all the stakeholders. Your orthopedic surgeon colleagues, the administration who's got to fund it, who's got to buy these machines that cost $50,000, $60,000, $70,000, and nursing, right? Because they've got to help you in the recovery room, right? They start pushing opioids in the recovery room. This is all for nothing.
Yes, agreed. So from there, So it goes well. I'm assuming the first patient does well. You actually got all of these people to develop consensus and agree and allow you to do this, which is pretty amazing.
Yeah, that was pretty amazing. And honest to God, I didn't sleep the night before, I'll tell you that much, because I'd only watched somebody do an ultrasound and got a nerve block. But I've been doing femoral nerve blocks blindly for a long time. At least I have eyes.
Well, yeah, I was going to say one of our mainstream things we always joke around about in medicine is, right, you see one, you do one, and then you can teach one, right? So there you go.
That's kind of how that went. And, that just led into buy-in from the hospital, and it was about changing the culture of pain. And that led to doing blocks and for colorectal surgery. And then we started writing some papers, and then on to breast surgery, where young women were having mastectomies. Breast cancer was rampant in Fairfield County, Connecticut, sending patients home with nerve blocks, and these women having no narcotics post-operatively. And a lot of these women are young children, right? They don't want to be zonked out. And they want to go home post-op day one. And the longer acting local anesthetics allowed us to do that. Now they were getting pain leave for 36 hours.
Yeah, amazing. And so tell us about the story of the Stanford School of Regional Anesthesia. Obviously, you became very passionate about this, and you wanted to make sure that you could share and educate others, which I love about you, Theresa. It's one of your absolute superpowers. But tell us about the creation of that school and where it is now and what's happening.
So I was on the Speakers Bureau, like I'm sure you are and a lot of our colleagues. And so I was traveling around the country teaching people how to do nerve blocks. And it was really exciting in the beginning, right? Because we're doctors, right? We live in an operating room. We don't do anything. And all of a sudden I was getting on a plane and going wherever I was going. I found myself one time in a gun club in East Paris, Texas. And I realized that maybe this wasn't what I wanted to do all the time. That was an experience.
And they're not just like, they have like AK-47s.
Oh,
I mean,
yeah.
you can shoot anything you want.
Picked me up in a pickup truck with his gun rack, and I knew I was not in New Canaan anymore.
I love it. I love it.
So I was with a rep in New Jersey, and I'd been doing it for a couple of years. He said, "Hey, Dr. Bowling," he's like, "you got a pretty good following here. What are you doing this for? Why don't you just do it on your own?" And I said, "You know what? You're right." And I got on the train back to Connecticut, and I wrote a business plan, and I got a tax ID, and I hired people to work for me. But the thing that was different about my course, which was teaching regional anesthesia, was what I knew from being on the road is you can teach people how to do a nerve block, but getting a regional anesthesia program off the ground is a whole different ball of wax. So I divided my program into half a day. The morning was having all of the key stakeholders talk about why regional anesthesia is important for them: surgery, orthopedic surgeon, a general surgeon, a nurse, an administrator. And then in the afternoon, I taught people how to do nerve blocks. So that's what made it unique. It was about learning how to launch a program and do the blocks.
And then I'm sure you wound up starting to get some sponsorship from the ultrasound companies, as well as the long-acting anesthetic companies that were all in this, to have gain as well for themselves. So it probably really caught on, pretty well. And is it still robust now to this day?
So what happened was I also realized that online training, right? Everyone's online now, and then plus YouTube. So, we'd done a load of YouTube videos. We had great following there. So I kind of parlayed off of that and hired a film crew, and we did everything, all the lectures, filmed. And then I created an online version of the course, which was great. That took off. And then courses became so expensive. And then, of course, sponsorship became harder to get, right? We had to start jumping through a lot more hoops. And the courses were expensive, right? Faculty costs a lot of money, bringing surgeons to Texas or Boston or whatever. And so I had the opportunity to sell the online course, and I took advantage of that to a medical education company. And then, of course, COVID hit.
Yeah, of course. That was even better than at that point. I mean, right? Because online's where you had to be.
Nowhere. And so what happened was, and then simultaneously, the Connecticut Orthopedic Institute was founded at St. Vincent's in Bridgeport by Hartford Healthcare. They asked me to be the director. And so my direction changed at that point. It just pivoted to something that I was passionate about. And at that point, I wasn't so interested in traveling.
Well, but you created something amazing, right? And you were actually even able to sell it. So, I mean, that's sort of the classic entrepreneurial spirit. You identify a problem, you then, develop consensus, bring people together, and then you make a difference. And then hopefully, you have an exit, you can sell it, and what you put together was worthwhile doing. So, congratulations.
It was a great experience. We had so much fun. I mean, I had some of the best orthopedic surgeons and some of the best regional guys. I mean, we would have so much fun because we were all passionate about it. And I think that's what drew me to you. You're so passionate about what you do. When we went to Honduras, your positive karma, I just fed on it. I've got a lot of energy, as you know, Scott. And so you and I together.
We're going to talk a little bit about that too. This is a great segue. So for our listeners, Theresa is dear friends with Michael Redler, who was obviously everyone knows, a dear friend of mine, my brother of another mother. And so we all went down to Honduras, where we worked with One World Surgery, which was put together by Peter Daly and Lulu Daly, which is just a phenomenal experience. And we'll share a little bit about that. But we got to spend a week with each other. The esprit de corps, being in the operating room together, having never worked with each other. I brought Marcia Bergen, who's our lead anesthesiologist, down as well. And we had Tori was there. We just had an amazing group of people that had really never met before, but really gelled beautifully together.
Just fantastic. I mean, it would have been my bucket list. As we're getting older, there's things I want to do. And that's been on my list for a long time. And Mike Redler had, mentioned to me years ago. So he finally texted me in September. He's like, we're going in December. You're coming. Well, orthopedics. And I was like, I'm in. And I signed up that day. And, I remember now that I look back, you were sitting behind Tori and I on the airplane. And I could spot cool. Trouble already. I go, these guys are trouble. I don't know who they are. I don't know if they're on this trip with us. And Mike Redler's like, hey, meet your new orthopedic surgeon colleagues. I was like, oh boy.
And then it was so funny because you and Tori were like talking about lectures, and Tori looks around. She's like, yeah, I lecture. I was like, oh, okay. Oh, that's good. Well, we lecture a little bit too, but this is going to be a lot of fun. We can't wait. And then, of course, we brought down, thanks to Pacira, we got to give a huge shout out to Pacira that gives us a case of liposomal bupivacaine Exparel every time we go down. Sonosite was there with their ultrasounds that they had donated. And you and Marcia were just popping out blocks like they were going out of style. And we just had it was such an honor to care for these people. They're so deserved.
Yeah, and a shout out to Marcia, just loved her. I mean, everyone, the synergy was just incredible. I just want to, point out or, tell our audience a little bit about that one case we did with that frozen shoulder.
Yeah.
One of the take-home points I learned there with among so many was, how much you could do with so little, right? And, we had that patient who took Ozempic, remember? And she had the frozen shoulder. She had that for, we don't even know how long, years, had traveled who knows how many hours to get to the clinic. And she tells me she took Ozempic. Now, if we'd been home, we would have canceled the case, right? But I came and talked to you and to Mike and said, how can we do this? Let's figure this out, right? And we all worked together. And you said, listen, if you can block her and make her comfortable enough, I'll tweak her shoulder and we'll get it done. And I kind of looked at you and you looked at me and you said, if it's safe. And I said, it's safe. We won't put her to sleep. And we did it. And a great picture of her with her shoulder over her head. Remember that? And she walked out of there and she used her arm, man. It was super cool.
It was awesome. We had everybody around us because we had a couple, there's some residents that are down there as well. It was a wonderful teaching experience. And, we just gently manipulated her arm under the regional anesthetic. He gave her a little bit of sedation too. And she did an amazing job. But what was most amazing, I don't know if you remember, but we got a video back from the residents who had seen her 2 weeks later, and she had near full range of motion to her shoulder and was just so happy that she had been cared for. It was just such an amazing experience.
I mean, amazing. Like, I can't wait to go back next year. I'm looking forward to it already.
Yeah, no, one of the things I got to bring up, and yeah, I'm sorry. You knew it was coming, Therese. No, but one of the things that's super cool, what's the number one thing that's happening around the world right now? And that's pickleball, right? And so they literally made a pickleball court inside the pavilion in which we would have dinner and every single night. So there would be these pickleball events. And so, Theresa, she's really dialed in case you haven't noticed it. She is when she's doing something, she's all in. So she comes out. There's like lead-in music that they're piping in. She's got her hat around backwards. She's got her sunglasses on, and she's stretching around and moving. You were in the dark corner, and I swear to God, you were blind as a bat. I don't think you hit one back.
It's so horrifying. I can't even. And it had you as the net judge. I mean, I have to say, well, you have to be honest. It was very, very dark, and eyes weren't so good. But a couple of pickleball clinics since then. I'm prepared for the rematch next year, as long as we do it during daylight hours.
I love it. You can bring your ophthalmologist prescription to say that that's the case. You're going to need a special exemption. But and then I remember Redler. I was really surprised at how well Redler was doing. I mean, when he jumped, he actually got like 6 inches off the ground. I don't know if you saw it. It was amazing. But literally, he just was really hitting the back like Andre Agassi. It was so much fun and memories that I have forever. I can't wait to get the team back again for this year or early next year for sure.
Sure.
Listen, Theresa, this was amazing. This is exactly what I knew it would be. You're such a dynamic individual. You have just an amazing way of explaining things to people. You are a leader within education. You've been passionate about your career over 30 years. And we are just so thankful that you've taken the time out of your busy schedule to be here and share your time with us today.
Scott, again, thanks so much. And, I'm so blessed to have met you in Honduras, and we've become friends, and I look forward to a long friendship with you.
Absolutely. It is my pleasure. This is Dr. Scott Sigman, #FollowTheFro, host of The Ortho Show. Till next time.